Looks promising.
Hello.
Hello?
Hello. All right. So there's one person. I'm trying to get everybody else on here.
I don't know if everybody saw that link.
We'll get it here in a second.
Oh,
This is very silly, so bear with me. I think I'm just gonna have to copy and paste everybody from the email.
Is that Michelle on there too?
mhm.
What's that?
Hi, Michelle.
Hi, Michelle.
Hey guys!
Hey,
I totally turned off my camera. I was like,
That's okay.
nonsense.
I have mine turned off as well.
I don't have a camera.
Recovered, I should say.
Let me try and resend out an email to everyone with the new link quickly. Do. And I think there's a little chat feature where you can start typing questions. So if you guys want to just kind of one at a time, we'll start answering questions.
The Q&A feature is disabled.
Okay, one second. Let me see if I can enable that. Do.
I got the chat.
Okay, there's a new link sent out to everyone. And let's turn on the Q&A.
Hey James!
Hey!
A beer, nice. And so is Gabe.
No, it's a root beer. All right, here we go. Chat. Great. Everyone is chat. All right, so I think most people, ASL, we're not going to play those jokes. All right, so I think most of the people who said they would be message everybody, maybe.
You had 90% of the trade Brian Arthur, so you should be.
Okay. All right. So, question regarding axis deviation. How do I understand to look at V1 and AVF? I am just unsure how to determine the degree of deviation. Okay, so let's go back to the lecture on axis, lecture 2. I think I could share my screen here. Screen share. Screen. There we go. Can everybody see my screen there?
Yes.
Great. All right. So, Dropbox. Sharing. EKG. And we'll go to lecture 2. Pull that guy up. All right, so it should be pulling up here in a second. So there's two methods, right? The first method I taught you was looking at lead 1 and AVF. I think that this method is the simplest, and that's why I taught it first. Basically, we're using those two leads to narrow down the possible options to 4 possible options. Either axis is normal between 0 and -90, right axis between -90 and 180, or left axis between 0 and -90. Can you guys see that? Yes? Okay.
Yes.
Yeah.
Or the fourth option being far right, or indeterminate axis, somewhere in here between -90 and -180. Okay? So lead 1 points from here, from the west to the east. Okay? And AVF points from the north to the south, right, from top to bottom, so that your head is up
Right
here.
to left.
Say that again?
So right to left for lead 1.
Yeah, right to left for lead 1, from your right side of your body to the left side of your body, meaning the negative portion of the lead is here and the positive portion is here. And lead F, AVF, points from the top towards the bottom. So let's draw an arrow. Actually, let me just pull up their talk real quick. So by looking at these two, we can get a sense of which of the 4 quadrants the axis is in. Because we're just looking at this lead and this lead. If it's positive and moving towards both 1 and AVF, then the sum of the vector, if we add up the vector going this way and the vector going this way, the sum would be somewhere in this quadrant. So all we're looking at is the sum of 2 vectors. Okay? So using just these 2 leads, we can determine if it's positive in 1 and positive in F, then it's moving leftward and downward. Put those together and you get down and diagonal. Okay? So then the opposite is true, right? So if we flip that whole thing around, if instead it's negative in 1 and negative in F, then it's moving rightward and upward. So that means it would be up somewhere up in this quadrant. And moving along that, if it's positive in 1 and negative in F, then we're in this quadrant. Okay? And if it's positive in F, moving towards your foot, and negative in 1, moving towards the right instead of the left, then it's somewhere in this quadrant. So that's how you narrow it down between the 4 quadrants. Now to go further, to narrow it down to one of these increments of 30 degrees, I apologize because these lines aren't perfectly 30 degrees apart, we would look at the leads within that quadrant. Okay, so if we're in the normal axis and it's positive in 1 and it's positive in F, and now we're trying to determine, all right, is it closer to F? Is the main vector, the sum of all the vectors, closer to F? Is it closer to 2, which would be 60 degrees? Is it closer to here, which would be 30 degrees, which is the opposite of AVR? Or is it closer to 1? We would basically look at these 4 leads and determine of those which one has the largest magnitude, whether it's positive, positive in 2, positive in F, or negative in AVR. So let me point to that EKGpedia site because I thought that was a really good little tool. It allows you to play with EKG. And go from there. As that's coming up, so the other questions are, what does far right indicate? Do we need to know? Far right, the differential for far right you won't need to know for right now, but the differential includes things like dextrocardia, like ventricular tachycardia, like extreme vertical heart, which is where if you have COPD lungs that are fully inflated and long and narrow, sometimes your axis can be shifted over so far over to the right, etc. But mainly I want you to focus on the differentials for left axis deviation that you see here and the ones for right axis deviation that you see here. You see dextrocardia is also on here, and that's okay. Sorry, one second. All right, so let's go to this tool here. All right, so if we know that our axis is somewhere between 1 and F, and we're trying to determine where it is closer to, let's say the axis is right here. We see that it's positive in 1, positive in F, so we know it's somewhere in this lower quadrant. And now let's try to narrow it down. Is it closer to 0, 30, 60, or 90? What we're going to look at is leads 1, AVR, which, if you keep drawing this line, goes over here, lead 2, and AVF. Okay, so what we're looking for is the one that has the highest magnitude. So if you compare the magnitude of this QRS wave to the magnitude of this AVR, and you're trying to determine where it's closer to, either AVR, which the reciprocal of AVR is here at 30, versus this positive portion of lead 2, you could say pretty easily that this amplitude is larger than this amplitude. A little bigger. Okay. And let's say the real axis was actually closer to here. You could see
That's cool.
that AVR, the magnitude here, is slightly bigger than 2. Now, I'm going to tell you, this tool isn't exactly perfect. So while I'm trying to explain this, it may look like these are almost equal, and that's okay. But in a real-world example, you would say, okay, because AVR is larger, the amplitude here is larger than this amplitude, it's closer to AVR, so it's closer to 30 degrees. And it's definitely not, the amplitude of those waves is definitely not as big as AVF, right? So it can't be near AVF. And it's pretty large in 1, so maybe it's closer to 1. So let's try one more example before we move on. So let's just spin and go random. Okay. So using our method, we look at lead 1, which is negative.
Can you do one where it's biphasic or isoelectric in 1 or AVF?
Sure. So let me first finish this. So it's negative in 1, so it's moving away from 1, and positive in F, so it's moving somewhere downward. So somewhere on the bottom half of the screen. Shoot. Nope, didn't want to do that. So it's moving somewhere on this half. Can somebody see that? Can you guys see that? Because it's positive in F. And it's moving somewhere on this half because it's negative in 1. So when we add those two up, we get this quadrant. All right, so then let's try and figure out, is it closer to 90 degrees, 120 degrees, 150 degrees, or 180 degrees? So let's look for the one lead of AVF, 3, AVL, and 1, and decide which one its largest magnitude. Okay, so 1, looking at this portion, this large negative portion. L, looking at this negative portion. 3, looking at this negative portion, this positive portion, and F. Well, you can see that if you compare those 4 amplitudes, this was definitely small. So it's not near AVF, not near 90 degrees. It's probably closer to 180 degrees, or AVL. And like I said, this tool isn't perfect. So, I mean, I have to admit, it kind of looks like 3 is the largest here. But that's what you would see. Now, the second method that I taught you guys was isoelectric, and I just briefly went over this in the 3rd lecture. And that's how this tool works. It's picking an isoelectric lead, one that is equally positive and negative, or the one that is the most equally positive and negative, and saying, okay, if AVL is the isoelectric lead, then we know that the mean vector has to be pointing perpendicular to that, either perpendicular this direction or perpendicular this direction. So that's step 1, right? So let's do it like this, where it's perpendicular to lead 1. Okay. So we know that because 1 is the most isoelectric of all these leads, then it's pointing perpendicular. So it's either pointing this direction, downward, or this direction, upward, because it has to be perpendicular to lead 1. Okay, so now we determine, okay, we have 2 options. Is it down or up? So next step is just to look at the lead with the tallest R wave, the tallest positive movement. And we say if we can look, it's either 2, 3, or AVF, right? Because those are the ones that are the most positive. And what this tool is trying to show you is that AVF is the most positive. So the vector is pointing this direction. And again, this tool isn't perfect, but this is, should give you a better idea. There shouldn't be a max on this broadcast, but if there are people who can't get on, there are some people who say they're unable to get on. Is this recorded or is it just possible to watch that? There's James, there's a second link that I sent out because the first one I was fiddling and I think I just stopped it and it's me sneezing and I apologize. So I sent out the second link and hopefully people received it. Let me see if there's anybody who responded to the messages. I tried to join the view, but the other link that says this call is full. Can't join either. This is supposed to be for up to something like 30 or more people. So I apologize if people can't join. Let me try and paste that link again. Try again. Yeah. I wonder if when people joined, they clicked on the video that's in there first, but Okay, all right, moving on. So was that helpful for access?
Yes.
Yes, okay.
Makes sense.
Are there any further questions with access? You guys had asked about the differential. Well, the differential is in the lecture for each left and right. You can also find it in any of the books that we recommended. And yeah, basically what you should know is anything that increases left filling pressures, like ventricular hypertrophy, right? Hypertension, which isn't on here, but it would be. Or anything that disrupts the conduction down the left side could cause a left axis deviation, right? Because a left bundle branch block can cause a left axis deviation. Anything that causes right-sided pressures to go up, can cause right axis deviation. The reason is, if you think about what causes these vectors to become larger and smaller, it's the mass of muscle on that side, right? So at baseline, in normal physiology, your left ventricle is larger than your right ventricle. And it's working harder because it's working harder to overcome systemic blood pressures, which are higher than pulmonary blood pressures. So in normal physiology, the left ventricle makes up the majority of the vector, and that's what I had hoped to show here in this diagram, was this larger arrow here compared to the smaller one from the right. If, for some reason, the right side is working harder, then the vectors are going to be shifted this way, down to the right, and vice versa. If the left side is working harder, then it'll be shifted over this way. Does that help?
Yeah, I think so.
Okay. All right, the next question was, how do we differentiate between a hemiblock and an incomplete branch block? So an incomplete branch block is kind of a diagnosis of exclusion. Have you guys heard that term before?
Yeah.
Yes.
Yeah, so it's kind of like something you reach for at the end when you're not quite sure. An incomplete bundle branch block is something that it has the same QRS morphologies as a full complete bundle branch block, but it doesn't have a wide QRS. The QRS will be less than 0.12. So what you see is something like this, right? We see an RSR prime pattern here, but it's narrow, right? So this is something that would be an example of a incomplete bundle branch block. Now, the diagnosis of hemiblocks can only be made when there's no other reason for an axis deviation. So, and I think I put that in the notes section here. Yeah. So let me get rid of these guys. So, what we see here is a QRS that's less than 0.12, and there's no other reason for left axis deviation. So to know that, you would need to know what kinds of things are on differential for left axis deviation. So in this lecture here, I put in the differentials for left and right. So if you see criteria for left ventricular hypertrophy, which we'll learn in the next lecture, but you don't really need to know what they look like at this point. Or if you see examples of WPW, which we went over in the first talk, or if you see examples of left bundle branch block, then you can't make the diagnosis of left anterior hemiblock. The hemiblocks are also kind of a diagnosis of exclusion. The reason I teach them to you is because you have to know what a hemiblock is. And you have to know that in the absence of any other reason for left axis deviation, then a left axis deviation would be due to a left anterior hemiblock. I think that sounds a little roundabout, and I apologize, but posterior and anterior hemiblocks should be on your differential when you see left and right axis deviation. So the question being, how do we differentiate between a hemiblock and an incomplete branch block? I would say that if you saw a narrow QRS, one that's less than 0.12, but it kind of looked leftward, or I'm sorry, like a left bundle branch block or a right bundle branch block, then you would code incomplete left bundle branch block or incomplete right bundle branch block before you code left anterior hemiblock or left posterior hemiblock. So I guess on the list of possibilities, and that's, I think I tried to follow that order in the talk. Let me see, where am I at here? There we go. So we talked about bundle branch blocks first, because those are the things that you should be thinking about first when you see a long QRS, right? And then we talked about hemiblocks. So really, this probably should be down here. Let's see, can it work? Yeah. And a subset of also right bundle branch block. So we talked about bundle branch blocks first, because those are at the top of your differential when you see conduction delay and changes in the QRS. And then we talked about maybe I'm not making this easy. So if you see a QRS that's less than 0.12, and it looks kind of like a right bundle branch block or a left bundle branch block, then you would call it an incomplete bundle branch block, like this. Or if it just is between 0.1 and 0.12, then you could call it an intraventricular conduction delay. Again, the point being is if you see a narrow QRS, but something that kind of looks like a bundle branch block, it would just be called an incomplete block. Whereas a hemiblock really just refers to axis deviations without evidence of left or right bundle branch block. So this is a perfect example, right? You see axis deviation, but you don't see QRSs that look like left or right bundles in V1 and V6. Okay. Beating a dead horse, I think. Okay. Next question.
Would you care to go over some of the homework, like the ones that people seem to miss more?
Would I care to go over the homework? So yeah, sure. Let's go do that. I'm gonna stop sharing my screen for a second so I make sure I don't share anybody's scores on accident. Does it say how many people are in here, by the way?
Okay, I'm in.
Okay, cool.
Okay.
I'm going to go ahead and mute you. Sorry, Corbin, I just muted you so it didn't echo. But please unmute yourself if you have a question. Sorry, I'm trying to pull up the item analysis for the last homework. Okay. Show my broadcast again. Screen 2. And can you guys see my homework? Oh, shoot.
No.
Or see my screen?
No.
Yes. I
Yes.
can see.
Okay. So this is the item analysis for the 10 questions. And it was 5 questions on bundle branch blocks and 5 questions on arrhythmias. So, funny thing is, I think most of you guys got the bundle branch ones, but the arrhythmia ones were, I guess it was a mix. All right, so average score. So the first one, the question was, what's the conduction delay? And the answer was left anterior hemiblock. The reason is this QRS is less than 0.12. And I'm sure some of you guys had a hard time seeing it. And what I'll do is just zoom in. And I'm going to look for the QRSs. Did I press something? No. It says live. Make sure. Stop presenting. Can you guys still see my screen?
Yep,
Okay.
I can.
All right. I'm going to hope that you speak
Michelle
for everyone. So I'm looking for a QRS that has a nice, sharp beginning and end, right? So this is a perfect example. So here you see the QRS starts here and it ends here. So all I'm going to do is count up the boxes, right? So it starts right here. So we could see a line, a yellow line right here, or a red line here. So 1, 2.5. See that? Kind of ends right there. So 2.5 boxes would be 0.1, right? So this is not greater than 0.12, which is what would be the first criteria for a bundle branch block, right? And so it's not a bundle branch block. So then we go down our differential and we think, okay, is it then a non-specific interventricular conduction delay, or not an incomplete block, or is it a hemi-block? Well, it doesn't quite look like a left bundle branch block, right? Because a left bundle branch block should have a nice tall R wave, kind of slurred, more positive than negative in V6, because V6 overlays the left ventricle. So it's not an incomplete left bundle branch block. So then we got to ask ourselves, is it a left anterior or left posterior hemi-block? Because it's definitely a little bit long, right? So we look at lead 1 and AVF, and we say, okay, 1 is positive, so we know it's moving leftward towards lead 1, and F is negative, so we know it's moving upward towards the head. So when we add those two together, that's left axis deviation. And left axis deviation is consistent with left anterior hemiblock. So that's why this one is left anterior hemiblock. Some of you guys answered left bundle branch block, but again, this isn't greater than 0.12, so it doesn't meet criteria for that. This isn't normal conduction because we just talked about how it's slightly wide, and you know, it's a lecture about bundle branch blocks, and then posterior is the opposite of what we're showing here. All right, so let's move on to the next. Any questions about that?
Nope, that makes sense.
Okay. And everybody else, feel free to unmute yourself and ask a question at will. The next question here, this one is a bundle branch block. If we look at the width of the QRS, let's find one that starts like kind of right on our wave here, right? And has a good beginning and end. Probably here. This is a good lead to look at because that is, or here. So it starts right here. And it ends all the way over here. So it's almost 3.5 boxes. Right? So this meets criteria for a bundle branch block. This is already greater than 0.12. So if it's greater than 0.12, the next question is it left or is it right bundle branch block? Well, sorry, let me turn off my notifications here. To differentiate between left and right, let's first start with looking at V1. And we see that the majority of the force is negative, moving away from V1. And we know that V1 overlays the right ventricle. So we know that there's all this negative terminal force moving away from V1, moving away from the right ventricle. So instead, towards the end of the QRS, moving away from the right ventricle. That means it's moving towards the left. You can see this is more positive than negative. Okay, and then the other thing that's helpful but not necessary for the diagnosis is there is left axis deviation, right? Up in 1, down in F, away from F. So some folks answered incomplete left bundle, but again, we know that this is greater than 0.12. Some people said incomplete right bundle, but we would have a totally different morphology here, right? We would have that RSR prime, or a terminal positive portion of the QRS in V1. Some people wrote non-specific interventricular conduction delay. Well, for that to be true, the QRS would have to be less than 0.12. So if you're ever having trouble seeing this on a screen, I think what you should do is do this kind of thing. Let me see if I can stop my screen sharing. Grab a sheet of paper here. This is my student loan bill. All right, so let's do this. I'm not sure if this is totally going to work, but let's see here. All right, so if you're looking at it, the best thing to do is draw yourself what is exactly one. Hold on. No. Draw yourself one box. Can you guys see me doing this?
Yeah.
So I'm drawing one box here. And now I'm going to say, okay, if it's greater than half of this, we know it's pretty close to 3 boxes. There's only 5 boxes in a big box. So we look here, and I'm lining it up. Let's see, here. Lining it up here. Can you guys see that? Trying to line up the left tick mark with the beginning of the QRS. And I see that the QRS ends more than halfway through that box. Does that make sense?
Yeah, I just have trouble like finding the starting point of the QRS and then the ending point.
Yeah, and that's why it's helpful to review all of the leads to look for ones that have a nice sharp beginning and end. Is that a dog? Yes! Yay, a Dalmatian. That's awesome. Okay. All right, so that's that question. Let me go back to sharing my screen. All right. The next question is here. What's the rhythm? So this one is pretty clear. I think some people answered third degree or flutter, and I think maybe some people confuse these two waves for flutter waves. But if these were truly flutter waves, then you would see another one that marches out right about here, at about the same distance between these two. So if the interval between here and here is about 5 millimeters, or really probably about 4.5 millimeters, and the other wave would be about 4.5 millimeters here. Because atrial flutter waves are going to be regular. Remember that circulation, that circular circuit that develops within the right atria that creates that constant beat after beat after beat. So
you're looking for a regular rate with that?
no, what you're looking for is a sawtooth pattern of atrial waves between QRSs. Let me show you an example here. Like this. See sawtooth? And it's this circular pattern here, the bigger one. Let's see if there's another example. So this is a perfect example of flutter waves. Those are perfect flutter waves in there. You see how sawtooth they are? They're very characteristic. Now, what you notice here is that you have variable ventricular response, meaning here it's 1 atrial beat, 2 atrial beat, 3 atrial beat, score, right? Ventricle response. Whereas this one, it's 1 atrial beat, 2 atrial beat, 3. So here it's 1, 2, 3, 4 to 1. Here it's 1, 2 to 1. Here it's 1, 2, 3 to 1. So you have and this happens pretty rarely, but here you have an irregular ventricular response with a flutter. And it's clear flutter waves. More commonly, and this is the most common way you'll see flutter, is 2 to 1. Meaning you have atrial flutter waves, usually at 300 beats per minute, and every other beat results in a ventricular response. So the second atrial beat is buried here at the beginning of the QRS. So this one would look like this if it wasn't added to this QRS.
And so the P waves will be at 300?
Yeah, the P waves will be at a rate of around 300, plus or minus 10 beats, really.
And then compared to the homework question, the QRS complex, will that be, like, should that be more exaggerated since it's not very in lead 2?
You mean in amplitude?
Yes.
No, the amplitude has nothing to do with the diagnosis of atrial flutter.
Okay.
Yeah. The amplitude of the QRS is going to be more proportionate to the size of the ventricular muscle, right? And again, we'll go over this in the hypertrophy talk on Wednesday. But the size of any electrical wave you see is directly proportionate to the amount of myocytes that are generating that electricity, right? I briefly touched on this in, I think, one of the first talks when we talked about waves. Talked about waves up here. I think it was the very first talk. So we said waves have two main characteristics. Well, really three. First, amplitude, right? Second, duration, and the third, morphology. So first we went over duration, right? Then we went over amplitude. We talked about how the height of these waves is directly correlated to a certain amount of electricity, right, millivolts, and that electricity is generated by myocytes. Okay?
Mm-hmm.
All right. So back to that question, if you take the standard approach, right, rate, rhythm, access, intervals, then we see here that the PR interval is prolonged. Starting here, we can tell it's already longer than one big box, which is 0.2. Right? It's probably more like 0.24. So this is first degree AV block. The other option choices were Mobitz 1, Mobitz 2, which nobody answered, third degree block, or flutter. We went over flutter. Third degree block, again, and I think I wrote this in the feedback responses. Were some people having trouble seeing the feedback responses?
Did you do it on every question?
Yeah.
Mine didn't have it on every question, at least the last time I checked.
Okay.
Yeah, only about half of the questions.
Okay. Well, they should all be up there now. If they're it did take me some time today during my shift to get them all up there, but they should all be up there. Anyways, third degree block means that there's complete block of conduction between the atria and the ventricles. So the atria would be marching to their own beat, and thus the P waves would have their own rhythm, and then the ventricles would have their own rhythm, and there wouldn't be any association because again, what we're looking for is a P for every QRS and a QRS for every P. And here we see that. We see a P, a QRS, a T, a P, a QRS, a T, a P, a QRS, T. There's no P waves in here that aren't associated with the QRS. So that's why it's not AV block. Let me see if I can show you an example of third degree. I think I showed some in class, but let me see if I can find some more here for you. So this is a good one. So here we have a rhythm strip. And remember, a rhythm strip is just a single strip or maybe just two lines or two leads, and it's usually only 6 seconds long. When somebody hands you a rhythm strip, it's literally going to be a small strip of paper. When somebody hands you a 12 lead, it's going to be a full 8.5 by 11 sheet of paper. So,
do you know what lead this is?
What lead this is? No, it doesn't say, but it doesn't really matter.
Okay.
For this purposes. It's probably lead 2 based on these P waves. P waves should normally be upright and monophasic in lead 2. Right? And I think this criteria is in the second talk. When we talk about P waves, rhythms, AFib, intervals, segments, PR. PR. Maybe it's in the first talk. There you go. P waves. So normally in lead 2, they should be upright, and lead 1 as well. Inverted in AVR, and biphasic in V1. Remember, the first half is representative of the right atria, and the second half is a representative of the left atria. So here this is probably lead 2. Why is this third degree AV block? Well, what you're seeing is 2 ventricular responses. 2. What we see is a lot of P waves. 1, 2, 3, 4, 5, 6, right? And when the P waves come, the QRS has variable response, right? The PR segment here, the time between the atria depolarizing and the ventricles depolarizing, is completely variable. Another way to look at this is to try and draw. See if I can do this. 1 second. Use my handy dandy piece of paper, and I'll draw the peaks of 2 P waves. So my pen will work. Here's one. Here's one. So now how do I tell if all those waves I'm seeing are P waves? Well, if they're P waves and they're normal, all originating from the sinus node, then they should happen at regular intervals. So let's compare this one to this one. Yeah, they're the same, so that's the same interval. Same interval. Same interval. Right? Those are all the same interval, so they're even. So that means the P waves are marching to their own beat, and the QRSs are marching to their own beat. So that's third degree block. Oh, this is a great, I should have included this in my talk. So you can kind of see the significance of AV block with regards to first degree AV block, second degree AV blocks, and then high grade or third degree blocks in the severity. This is where you start to get worried. All right, so let's move on. Questions. You're asking a question always. On a strip in a clinical setting with the QRS width listed, is that number reliable, or any of the listed widths and segments? No. I would say that more often than not they are, but you would be surprised how often they are incorrect. It's a computer, it's following algorithms, and it usually does a pretty good job, but there are definitely times where it will incorrectly label something as, I mean, just today in our unit, we had a patient who was transferred in with a flutter, and we were going to cardiovert them. Well, we got an EKG, and it showed normal sinus rhythm on the read, but we all knew that this was not a flutter. So, yeah, keep in mind that the machines are not reliable. James, remember specific. Yeah. Still can see all the answer feedback response about half. Okay, well, let's keep going over some more questions.
I just have one question just regarding the exam for tomorrow. I know you said everything's has a chance of being on there. As far as like the disease states associated with,
yeah, I mean, you should know the differentials for left and right bundle branch blocks.
Right, the differentials, but do we need, like, are we supposed to be able to know which one specifically? Like, are we going to be using other types of information to figure out what differential exactly it is?
Well, sure. I mean, if I tell you that somebody comes in with chest pain and they have a history of hyperlipidemia and they're a smoker and they have a new left bundle branch block or a new EKG that looks like a left bundle branch block, and I ask you what the conduction delay is, then left bundle branch is the most likely answer. Does that make sense?
Yeah.
Yeah.
I just didn't know, like, if we'd have to pick out, like, oh, it's a volume overload, aortic regurg, you know, something like that.
Yeah, I mean, if you see a left bundle and I tell you that this patient,
Like, hear
yeah, maybe has some characteristic
stuff.
clinical exam findings, then yeah, you should be able to put 2 and 2 together.
Okay, that's what I was wondering.
Yeah. But you know, again, my goal is to be able to have you read the technical details of an EKG and understand what's happening, understand where electrical forces are going. Does anybody else have any questions before we move on?
No, I'm good.
Okay. Let's just go over one more question real quick. I probably have to go here pretty soon. We went over this one. No. So this is kind of one of the questions here. I'm trying to show right bundle branch block, and I actually ended up giving credit when I asked what the conduction was associated with this same EKG, because really this is probably really borderline. See, it starts here and goes to about here, so it's like exactly 0.12, you know, maybe just slightly less. But it's got this characteristic right bundle branch block. Anyways, the clinical disease state that you should pick out of this list should be mitral valve. These other things would likely cause left bundle branch. Let's see. One more. So this one, the P waves, I'm sorry, the QRS waves intervals irregular, right? You can pretty clearly see that this one is much longer than this one, and is different than these. So we say it's irregular. It's an irregular ventricular response. And we see some waves in between, but they don't have any particular morphology that's easy to pick out. They kind of look random, right? And when we see random waves, we think of fibrillation, right? And fibrillation between QRSs would be atrial fibrillation. So in this irregular rate with fibrillatory waves, atrial fibrillation is the best answer. Some people said flutter, but these aren't clear flutter waves. You would see characteristic sawtooth waves like we went over. A junctional rhythm would be regular. The R to R intervals would be the same throughout. And then sinus arrhythmia, there's no clear P waves, and you should still have clear P waves with sinus arrhythmia because it's originating from the sinus node. Okay, one more. Do we do this one?
Sorry, Gabe. What did you say the rhythm was on that last one?
This one is atrial fibrillation. I see some people answered junctional rhythm, but again, a junctional rhythm would be regular. And here, there's irregular R to R intervals. Okay, so those are some of the questions.
I know I had a question. Like I don't remember which one it was, but like where the QRS was all jagged. I just couldn't understand what was going on there. I guess.
The QRS is all jagged. All right. Well, there's only 10, so let's quickly go through this one.
No.
This one?
No.
Oh,
Sorry.
I think it might have been the ventricular tachycardia one.
Yeah, I think it was. I mean, that's what I put, but I just
And that was right.
think
This
about what was going on. And
Yeah.
jagged.
So this is ventricular tachycardia. It is, if we were to describe this, we would say that it's a regular rhythm, right? The R to R intervals are regular. They're evenly spaced. It's very fast, right? It's at a rate of about 300 and faster than 150, so probably 160, 170. So a rate of 170, and the QRS is wide. So here we worry about VTAC, right? A wide QRS that's fast, regular, we worry about VTAC. The other things that make this VTAC are there is AV dissociation. So when you look in here, you can see that there's not a normal pattern in between the QRSs. And in fact, this is a P wave here. This is a P wave here. There's a P wave buried here. And there's a P wave buried here. And I know that you're thinking to yourself, holy cow, how do you see that? Well, what I'm looking is just for pattern recognition. If there were no other waves between these QRSs, then they would probably all be perfectly humped like that, right? But you can see that this is not the same as this. It's not the same as this. And it's not even the same as this. And that's because there's buried P waves in there. And the hallmark of ventricular tachycardia is AV dissociation. So some people answered fib. That's not true. I mean, fibrillation would have totally chaotic patterns, nothing regular like this. Some people answered AFib. It's not AFib because it's regular. And if we do our paper test again, all right, I draw a one here, and even one here. I can slide this along and see that all of these are regular. They're all following the same interval. Everybody see that?
Yeah.
Yeah.
This is essentially what you do when you have calipers. But you don't need calipers, you need a sheet of paper.
So what makes the like jagged sides of the QRSs?
You're talking about the upward and downward slopes? I think that's just aliasing and how it was scanned.
Could you have a SVT with a wide QRS, like a bundle branch block that looks like that?
Absolutely, and that's one of the biggest things that you'll come into contact with in your practice is trying to differentiate true ventricular tachycardia from SVT with aberrancy, like a bundle branch block. Aberrancy just means that electricity is moving down a path that it shouldn't. It's an aberrant path. So if I asked you, the more difficult question here would be, is this ventricular tachycardia or is this SVT with aberrancy? And there are a number of criteria to go through and differentiate the two, but SVT with aberrancy wasn't one of the options here. And only pure AFib was one of the options. If I had written AFib with aberrancy, or AFib with bundle branch block, that could have been a possible answer. There would be some reasons why it's not that, and it's mainly, again, because you see some buried P waves in there. And AFib would be irregular. So that's about it.
So if this was clinical, that P-wave dissociation would be the biggest thing that would make you think it was VTAC
Versus AFib with aberrancy?
versus SVT with a bundle branch block.
I mean, there's a whole lot of criteria. There's criteria where you look at the AVR and whether it's positive or negative. You look at the downslope and compare it to the upslope. You look for fusion beats, which is a fusion of a ventricular beat, one originating from the ventricle, fusing with a normal beat coming down the sinus node and through the AV node. When the two fuse, the wave you see will be kind of mismatched and will in the middle of all the other regular beats. So fusion beats are characteristic of ventricular tachycardia. And then always, with any EKG and trying to figure out what it is, you'd compare it to an old one, or at least hope that you had an old one to compare it to. All right. So I think my time is up. I'll take one more question.
Okay, can I ask one more question about example and lecture?
Sure.
From the lecture 3, the bundle blocks that you asked about, slide 66. I was wondering why this is, where was it? Oh, I think I answered my own question, actually.
Okay.
I thought you said it's right axis deviation. I was confused by that, but that's not the answer. So I answered my own question. Never mind.
Okay.
Can I ask a question real quickly?
Of course.
It's one of the homework questions that asks what kind of bundle branch block is present.
Mm-hmm.
Excuse me, your screen.
This one?
No, not that one.
This one?
Yes. So I know it's a right bundle branch block, but then I'm trying to look and see if there's a hemi block and seeing the axis deviation from it. And it's kind of hard to tell with lead 1 and AVF. Like, how do you determine whether there is a hemi block with that?
Yeah, I mean, you could possibly say that because this is positive in 1 and a little slightly more negative in F, that
Right.
there's left axis deviation consistent with a hemi block. In which case, an option choice that said something like right bundle branch block with left anterior hemi block would be a good answer.
Would be right. Okay.
But I didn't give that answer specifically. You know, the answer choices were pure right bundle, pure left bundle, pure left anterior, left posterior. Now, for this question, because this QRS is like, I mean, it's like exactly 0.12, and I'm sure somebody could take out some digital calipers and show me that it's, you know, less than 0.12. I did accept incomplete and left anterior hemi block, just because I probably should have given you guys a one that was much wider to be very clear that it was right bundle. But yeah, the book that I got this from calls it right bundle.
Okay.
And again, it's that characteristic RSR prime.
Right. And so you would never have a diagnosis of a left bundle branch with a left anterior or left posterior hemi block. It would usually just typically be a complete left.
Correct. Yeah. So you can have. So we talk about bifascicular blocks, which is, you know, a block of the right bundle with a hemi block. Let me go back to the.
Right.
There are also things that called trifascicular blocks, and this is a term that, depending on which cardiologist you talk to, will agree or disagree with you. But a trifascicular block would technically be a right bundle with a left posterior and a left anterior. Now you're asking yourself, well, isn't that just a complete block? And that's where some cardiologists would say, yes, that's just a complete heart block.
Yeah.
But technically, if you were blocked down here and down here, your septal fascicle would still conduct.
Right.
So, well, I don't think I answered your question, though.
No, you did. You did.
Okay.
Yeah, thank you.
All right, guys. I hope that was helpful, and good luck on your midterm. And I'll see you guys soon.
All right,
Thank you.
thanks.
Thanks.
Appreciate all your help.
You're welcome.
Thank you.
Thank you.